Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. You can say that because I'm wearing a UT shirt. The cardiology seminars are brought to you by Triple N Media, and our YouTube channel has more than 200 cardiology lectures. We welcome you to watch them at your leisure. We also kindly request you to subscribe to our YouTube channel. I also have a cardiology rotations manual which you can get for free, and I'll tell you how you can do that at the end of this presentation. The feature presentation is Diastolic Dysfunction by 2D Echo Doppler studies. Diastolic dysfunction is one of the most disheartening conditions we deal with as cardiologists, and we need to understand how much of this diastolic dysfunction is reversible and how do we detect early diastolic dysfunction and try to prevent it from going to the worst possible scenario. Diastolic dysfunction. Here we can see the left ventricular and the atrial pressure mapped here. This is the normal function of the mitral Doppler, where we have the E wave due to the ventricular filling, followed by A wave related to the atrial contraction. And this is the mitral valve Doppler velocity. Then in the bottom we have the tissue Doppler from the septal or the lateral wall, looking at the annular movement during ventricular systole and diastole. As you can see, we also have the pulmonary vein velocity, which is a sort of a reflection of what's happening in the left atrium due to the impedance to the flow of blood into the ventricles. Normally, you have an E wave, which is due to ventricular filling. Then we have the atrial kick. E wave is bigger than A wave. That is the normal configuration of the mitral Doppler velocity. In a case of impaired relaxation, pseudo-normalization or restrictive patterns, we see certain changes. In the early stages, we see the E wave amplitude decreases, the angle of E increases, that's the deceleration time. We have the A wave which becomes prominent, which is consistent with increased left atrial pressure, which is trying to force blood into the ventricles. As the condition progresses, as the left ventricular wall becomes more stiff, more inelastic, and loses its torque, the E wave becomes more prominent, while the A wave becomes less prominent, and it begins to look like the first stage, which is the normal, and hence it is called pseudo-normalization. I'll come back to see how we can differentiate that from the normal situation. And in a worst scenario where the ventricle is so restricted, it's like a rock, it's just moving like this. You have a prominent E wave which is due to the non-compliant ventricle, which is unable to expand, so the pressure is backed up. The pressure is backed up at the ventricular level, creating a very prominent E wave which is 3 to 5 times bigger than the atrial kick. So that's at the mitral leaflets velocity level. Then here we have the mitral tissue Doppler, which could be at the septal or the lateral wall. And this is sort of mirror images what we see in the mitral valve Doppler velocity. So here you have the E prime and A prime. It sort of matches. But look at what happens in impaired relaxation. The A wave is prominent as it is in the mitral valve velocity. However, during pseudo-normalization, here we see a difference where the E prime velocity was prominent, now it is less prominent, and so is the A prime velocity. So this is the difference which will help you to identify pseudo-normalization with the normal variant. In restrictive cardiomyopathy, both the E prime and the A prime are considerably reduced to less than 10 centimeters, and in worst cases less than 5 centimeters per second. So those are the main features which differentiate between restrictive, pseudo-normal, and impaired relaxation conditions. It's a lot more to that than what we are seeing in this picture. Let's look at some other things. Several textbooks have been written. One of them is from Klein and Garcia. There are several other books written just on diastolic dysfunction, and you can understand how much of hemodynamic understanding has been accomplished through these books and researchers. Here we have the same picture, which is sort of blown up, but correlating with the heart. As we can see, in patients with diastolic dysfunction, they have hypertrophic cardiomyopathy. They could also have infiltrative cardiomyopathy, or they could have restrictive cardiomyopathy due to constrictive pericarditis. In most of these conditions, there is impaired filling of the left ventricle during diastole. That's what's reflected in all these Doppler studies. Here's an echocardiogram as far as the technique of obtaining these Doppler studies. Here we have the mitral valve velocity, where the Doppler is placed right at the tip of these leaflets. We measure the velocity of the mitral leaflets, and here is the diagram, which is sort of upside down to match this one. And here's where we place this one. Then we have the tissue Dopplers, namely the septal and the lateral wall, where the tissue Doppler is placed right here to look at the annular movement or the velocity during the diastolic phase. And here is the mitral valve velocity, where we see the E wave, which is more prominent. Then here is the A wave. And in the tissue Doppler, you get a mirror image of what we see. We have a E prime and A prime. And this is an actual tracing of patients with diastolic dysfunction. This is a normal mitral E and A waves. And in mild dysfunction, we have prominent A waves, whereas the tissue Doppler shows a prominent A wave also compared to the normal situation. But as we get into moderate LV dysfunction or diastolic dysfunction, the E becomes more prominent, whereas the A wave diminishes in size, and along with the E prime, the A prime diminishes in size. Then in the most worst scenario, like the restrictive pattern, where the ventricle just sitting there like a rock, and that's when you see the E prime and A prime, their excursions are tremendously reduced to less than 10 centimeters, and in worst scenario less than 5 centimeters per second. Here is a very colorful way of displaying the same scenario of diastolic dysfunction. As we can see here, we have the tracings taken from the mitral tissue level, and you can see this E and A and the reversal of these changes. As we go through different grades, we have the tissue Doppler at the septal level. All these things put together, this is what happens. This is the mitral Doppler, and this is the tissue Doppler, showing the same thing. Well, a couple of things I want to bring to your attention is diastolic dysfunction is not just about stiffness. Normal heart beats like this. Number one, it is squeezing. Number two, it is twisting at the base. The apex rotates. Number three, relaxation, quick, snappy relaxation. So there are three functions that account for the normal left ventricular function. Number one, squeezing, rotating, and lifting the apex, and then ding, relax. Shh. Whereas in a patient with diastolic dysfunction, the squeezing is slow. The squeezing function may be normal, but the relaxation is slow. It's like slow. The rotation is reduced, and the diastolic recoil is sluggish. So there are three different functions, all of which are impaired in patients with diastolic dysfunction. And all of these, like diastolic time, along with the untwisting of the ventricle, associated with the failure to relax like normal, whereas hypertrophic heart, watch the relaxation phase, slow, whereas normal. Whereas here, hypertrophic, they increase all these parameters which we talked to you in the previous slides. And here, I'm going to focus on the most severe cases. There are two different varieties here, namely reversible restrictive disease versus restrictive disease. In grade 3, can we do anything to change the hemodynamics? I mean, that's the key. When patient is coming to the hospital in pulmonary edema and has a hypertrophic cardiomyopathy, he is having diastolic dysfunction, how much of this is reversible and who is reversible versus who cannot have any reversible changes? We may be able to relieve the fluid overload, improves little symptoms, but the hemodynamic changes, can we alter them? That's the key question. So let's focus on this severe diastolic dysfunction. We have some reversible component, and how do we differentiate that with the fixed component? First of all, the mitral valve, there is no difference. Mitral valve velocity. If you look at the mitral inflow during Valsalva, that's one difference where you're going to see you still have some degree of atrial augmentation in patients with some reversible changes, whereas in patients with fixed disease, it's like a rock, nothing is going to move it. So the atrial contraction is not going to change it. So the atrial component is not clearly augmented in this phase. So that's one of the main differences, because the rest of them, the E to E prime is going to be greater than 10 in both cases. Same thing with the pulmonary vein flow. You may not see much difference, but it is during Valsalva where you can see there's some augmentation of the A wave if there is some reversible component, and that is absent in fixed restrictive cardiomyopathy. And we always have a question as how do we really identify who has grade 3 versus who doesn't have grade 3? And here's a beautiful chart they came up with by putting several different parameters: the E velocity, the E prime velocity, A velocity, A prime velocity, along with the left atrial volume index, plus tricuspid regurgitation velocity of greater than 2.8 meters per second. By taking these three parameters, if all these three parameters are normal and there's no tricuspid regurgitation, the left atrial size is normal, and E prime is greater than 14, then if E to E prime is less than 8 and E is less than 50 centimeters, that's normal. We know that. Whereas if E to A is greater than 2, we are dealing with grade 3 diastolic dysfunction. How do we differentiate grade 2 from mild to moderate? That's a key feature which is being addressed here. So let us focus on this particular box and see if we can make some difference. And here is this particular box which is expanded here. The average E to E prime velocity greater than 14, the septal velocity less than 7 centimeters, or the lateral wall E prime velocity less than 10, and if we have a tricuspid regurgitation greater than 2.8 meters per second, if the left atrial size is greater than 34 ml per meter square, if you have 3 or 4 out of these criteria, then you are dealing with a diastolic dysfunction. If you have only 2 out of these 4 criteria, it's intermediate. If it's 0 to 1, then you're dealing with the normal diastolic functions. So this is a different way of looking at, because not everything is cut and dry. Oh, here's 0, here's 4, and here's 3. In grade 2 diastolic dysfunction, grade 1, everybody knows it's normal. Grade 4, it's like a dead horse. Everybody can identify that. It's the grade 2 where we have some question as to how do we differentiate from mild to a real case of diastolic dysfunction, and that would help us in this particular scenario by looking at these parameters and see how many points they get. If they get 3 to 4 out of these 4 points, then you're dealing with diastolic dysfunction. Okay, ladies and gentlemen, this is a very quick synopsis of diastolic dysfunction. As I told you, they have 1,000-page books written on diastolic dysfunction, but the problem is we don't have a whole lot to offer in changing the structure of the heart or its relaxation properties or diastolic function, except using diuretics to reduce the volume overload and perhaps using some drugs to help with LV hypertrophy. I hope this has been useful to you, and please do subscribe to our YouTube channel. And if you would like to get a copy of the Cardiology Rotations Manual, please send me an email to drniknikam@gmail.com, and I'll be happy to send you that. This cardiology seminar is brought to you by Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas, and please do subscribe to our YouTube channel. I will see you in the next video.